Nós estamos com o Dr. Paolo Rama, que é o diretor da unidade de córnea do Hospital San Rafaele de Milão, e nós vamos falar sobre o estado atual do transplante de córnea. Paulo, first of all, it's a pleasure having you here.
Thank you.
And we would like to talk to the ophthalmologist that is not in São Paulo or Rio nowadays, but maybe far away from us. And I'd like to let them know what's going on with the corneal grafts nowadays. So I will begin with a very simple question for you. Not a long time ago, if a patient had keratoconus, we would try contact lenses, and if it didn't work, we would go for a penetrating keratoplasty. How is it your approach today? How do you deal with a patient that has keratoconus and until it gets a corneal graft, and what kind of corneal graft would you suggest for this patient?
So nowadays for the keratoconus we are trying to prevent the progression, so to avoid surgery. And you know there is cross-linking today when possible. And second, for any other surgery, the rule is less invasive than as possible. It means that for keratoconus, nowadays we are proposing lamellar keratoplasty, which is mainly safer, can provide the same results of the PKs in terms of visual recovery and refractive error, astigmatism, but is safer. You can remove earlier the sutures, less steroids, so when possible, lamellar.
Since you talk about the anterior lamellar, would be the DALK, right? Deep anterior lamellar keratoplasty. Let's talk about the posterior lamellar keratoplasties. So what can I expect from a patient that undergoes to posterior grafting? Patient has Fuchs dystrophy and it undergoes a posterior grafting, DMAC or DSEC. In the past, it would take maybe 3 to 6 months to recover vision. Is it still the truth?
For Fuchs dystrophy, when the patient has a high expectations, nowadays we suggest DMAC. DMAC recovery is much faster. As soon as the graft is attached, they can gain 20/20 vision. And there is a tunnel, so the patient can have the sutures removed after at least a month. So it's a very safe and fast procedure with excellent results and very low risk of rejection. So just not a long course of steroids, so it's an excellent procedure. But when the expectations are not so high, DSEC it's easier, even if it takes a little longer to reach the best visual recovery. It is easier for the surgeon and less rebubbling, so less surgery for patients. So I suggest that the corneal surgeon should learn both the procedures.
Great. Assuming I'm not a cornea surgeon, and now I have a patient that has cataract. Let's say a nuclear cataract, 3+. This patient has Fuchs dystrophy. Again, in the past, we would go an open surgery, corneal transplant, and cataract extraction. So what guides you to decide, can I do just a cataract surgery and try to avoid the corneal grafting, or try to make the corneal grafting in a second turn, or I have to go and do everything at the same time? What guides you?
Age and expectations. So young age, I mean young age, 50s or 60s, with high expectation, with Guttata I suggest to do a combined procedure, DMAC and cataract extraction, phacoemulsification, because they can have the best visual recovery. For people that do not have a high expectation in the 80s and without edema, you can check the thickness of the cornea in the morning and in the evening. If there is a change, it means that is starting endothelial decompensation. In those cases, I suggest again a combined procedure. You can also propose a DSEC, combined DSEC with phacoemulsification. But if you already have some edema, of course you have to do a combined procedure.
So if the cornea is clear, you may try,
yes,
if it's not varying too much from morning to... Do you use any number on corneal pachymetry for... your
Yes, usually I consider, and sometimes I look also at the fellow eye, so could be, let's say, 620, 640, the risk, yeah.
limit. And so, since we are talking about it, there's a, I mean, some argument about the use of specular microscopy for Fuchs dystrophy in deciding the healthy or the health of the cornea. Do you believe that if I measure the corneal cell density with a specular microscopy, would it be helpful for me to decide if the cornea will or will not take the surgical aggression of a cataract surgery?
My personal idea is that the endothelial exam doesn't help at all.
Doesn't?
No, because what you want is the function of the cells. You can have a lot of gutta, but with well-functioning endothelium, they go quite well. Then you can have a high density with a gutta that impair the function of the endothelium. Let's say central gutta. Those are patients that need a combined procedure, and we don't look at the endothelium at all.
This is very good to know. So let's see if I can summarize it. The cornea must be clear,
Yes.
maybe less than 620 or to 640 microns.
Yes.
Don't look at specular microscopy. You can have a wrong information.
Yep.
And you can try the cataract surgery
Yes.
itself. If for some reason the eye doesn't take the surgery, you can do a DSEC or even a
Later.
DMAC later.
Yes, perfect.
Thank you very much, Paolo. I'm
welcome.
sure our audience liked it very much. It's a pleasure having you with us here.
Thank you very much. Thank you.